Hello, everyone. Welcome. Thank you for joining us. Families for Depression Awareness welcomes you to Nurturing Hope, supporting loved ones who have passive suicidal thoughts. We're so glad that you can join us this evening. We welcome your questions in the chat. And if you get a chance to put in there where you are watching from, we'd love to know that too. My name is Lisa Meekum. I'm a writer based in Southern California, and I'll be moderating today's panel. There have been a few times in my life where I have been a caregiver for someone struggling with a mental health challenge. And I understand how isolating and overwhelming it can feel to navigate systems of care, coordinate resources, and take care of yourself at the same time. Suicide in particular is hard to talk about because of the shame and the stigma associated with it. Families for Depression Awareness has been a tremendous resource for me in opening up conversations like this. And we are so glad to have everyone here with us as we begin our panel discussion about this important topic. A little bit about how this program will go. In a minute, I'm going to introduce our panelists joining us tonight. And then we will go through a series of questions about supporting a loved one living with passive suicidal thoughts. We encourage you to share your questions or comments in the chat throughout the discussion, and we will try to weave them in when we can. This program is being recorded and will be available to watch immediately after it airs. Finally, we remind you that we are doing a survey to evaluate our program. And so if you can stick around after our presentation, please do fill it out as it helps us to improve our programs in the future. I would love to tell you a little bit about Families for Depression Awareness. Our mission is to help families recognize and cope with depression and bipolar disorder, to get people well and prevent suicides. Our philosophy is that when a person is living with depression or bipolar disorder, it's the people around them, it's the parents, the siblings, the grandparents, the friends, all of those people in their life that really have a strong and powerful position to support a loved one, yet they don't always know what to do. And so that's where Families for Depression Awareness comes in. We provide education, training, and support specifically geared towards family caregivers so that they can be a strong advocate for their loved ones. They can be a partner in care, and most importantly, so that we can preserve family units, because that's what we really believe helps to improve health outcomes. The hub of our resources is our website, familyaware.org. Some of you may have already visited it, but if you have not yet had the chance, please go. And you'll see other webinars and workshops that we've had in the past and ones that are coming up in the future, and a tremendous amount of resources like web tools, such as a depression and bipolar screening test and a caregiver stress test. We also have a mental health family tree tool, and you can find loads of other resources, including family stories and expert interviews. Before we launch into our program, we want to thank our funder that made this programming possible. This program is supported by the Massachusetts Department of Public Health Suicide Prevention Program. Tremendously grateful for their support. And of course, for people like you, those of you who have given to Families for Depression Awareness, we so appreciate you believing in our mission and believing in our cause. We thank you for continuing to help us support these free programs on the issues of depression and bipolar disorder and how they affect families. We're really, really grateful for your support. It is now my honor to introduce the panelists that are going to be joining me for our discussion. Chiara Alvarez is a Bloomberg Assistant Professor of American Health in the Department of Health, Behavior and Society at the Johns Hopkins Bloomberg School of Public Health. She is a licensed psychologist and holds a joint appointment at the Johns Hopkins School of Medicine. Her research focuses on youth mental health equity, suicide prevention, and the well-being of Latinx and immigrant youth, including family-centered approaches to integrating mental health into primary care and community settings. She is on the board of directors for the Society for Prevention Research and the steering committee for the Youth Suicide Research Consortium. Welcome, Chiara. Very glad to have you here. And Johanna Louie is a licensed clinical social worker, passionate about caring for caregivers. And 10 plus years of working in suicide prevention, she has served in roles like crisis line manager and psychotherapist, as well as directed clinical training programs. In 2018, she co-founded Suicide is Different with Daniela Zanich. To this day, Suicide is Different continues to provide support services for both professional and family caregivers, caring for people thinking about suicide. Johanna holds master's degrees in social work from Columbia University and human behavior from the University of Southern California. Before we get started with our discussion, I'd like to share some important resources with you. On the screen now are some crisis resources that are wonderful to have on hand for you and for your family members, like 988, the Suicide and Crisis Lifeline, where you can call or text for 24/7 crisis support. The 211 number, which is an easy to remember telephone number that connects callers to information about critical health and human services available in their community. It serves as a resource for finding government benefits and services, nonprofit organizations, support groups, volunteer opportunities, donation programs, and other local resources. The Not Okay app, it's help that you can reach when you're feeling vulnerable. This app was created by siblings Hannah and Charlie Lucas after Hannah, a 15-year-old high school sophomore from Georgia, developed anxiety and depression after being concerned she might faint while alone due to a medical condition. The app's goal is to help users avoid entering the crisis zone and provide immediate support via text, phone call, or GPS location. The Trevor Lifeline for LGBTQ youth, you can call 866-488-738 or text the word HELP to 678-678. And the crisis text line, again, texting the word HOME, HOME, to 741-741 from anywhere in the United States, 24/7, free and confidential. Crisis text line is there for you, where a live trained volunteer crisis counselor receives the text and responds, all from a secure online platform. So those are just a couple of wonderful resources to have on hand for you and your family members. And then a couple of community resources, especially important when we think about the intersectionality of identity and mental health. These resources are specific to a loved one's identity and can be another great avenue to help your loved one toward wellness. It may be easier for your loved one to open up when they know the person they are talking to can relate to their identity. So there are a couple of very helpful resources there as well. Again, all of these are available on our website, familyaware.org. All right, well, we're going to go ahead and move into the panel portion of our program. Thank you again, Chiara and Johanna. Let's go ahead and start with you, Chiara, taking the first stab at this answer, which is, please describe the difference between active and passive suicidal ideation, and how can caregivers recognize signs of passive suicidal thoughts?
Absolutely. I'm very happy to be here and here with all of you having this conversation. It's very helpful to have a chance to talk more specifically about an aspect, right, of suicidal thoughts and behavior, which is passive suicidal thoughts. We don't often get to talk at sort of this level of detail. And so I think the important distinction here is when we talk about passive suicidal thoughts, we're typically talking about thoughts of wanting to die, wanting to disappear or not be alive, feeling that you might be better off dead, or thinking that others might be better off if you were dead. And so the reason we say passive is because when you're having passive suicidal ideation, you're not necessarily picturing yourself doing something to make this happen. You're picturing it happening to you in some way. And so when you're thinking about the contrast with active suicidal thoughts, you really are thinking about wanting to kill yourself, something that you yourself might do. It might not be specific, or it might be specific with a plan or a method involved. And so this does get tricky, I think, for caregivers as well as for mental health professionals to be aware of, because there can be a range in ways that people communicate this. For caregivers, I think it's just important, first and foremost, to be aware that these kinds of thoughts exist, that thoughts of suicide are not always about an active plan or knowing specifically what you might do. Um, and knowing that there are some questions that can be helpful. So typically we do recommend that people ask direct questions, even in your conversations with loved ones, that we ask direct questions like, are you thinking about suicide? But that might miss somebody who is only having passive suicidal thoughts. And so you might also ask things like, are you having thoughts about not wanting to be here anymore? Or have you ever wished you were dead? Because those thoughts can open up a little bit more of a conversation around passive ideation. And I think the other important piece is that you want to listen for more subtle indicators. So if someone says something like, no one would care if I died, or my family would be better off without me, or I wish I could go to sleep and not wake up, those are things that's something to be aware of, right? That's something to follow up on and have an open conversation. It's not just assuming that that doesn't mean anything, because it really can mean a more persistent, sorts of feelings of passive ideation. And the last thing I would note is you want to look at behaviors that could be risky or might put a person in a position to be hurt. And so again, they might not be doing something deliberate or exactly saying that's what they're doing. But if you're really seeing sort of reckless, risky behaviors, things that might put someone in a position to hurt themselves or to potentially die, then that is something to be aware of as well as potentially indicating passive ideation.
Thank you so much. Johanna, would you like to add anything on to that?
Yeah, I think the only thing that I really was thinking about on top of that really, really comprehensive answer is I think a lot about baseline and changes from baseline, especially when we're talking about kind of reckless behavior and whatnot. Um, if I know this person has always kind of been into extreme sports, I might be less concerned if there was a sudden interest in a new type of activity rather than like someone who's always told me no and then suddenly finding interest in something that I see as risky. Maybe wanting to kind of take their motorcycle out during like when there's a lot of traffic. I think what I'm trying to say is that like I think that can help us also find some nuance, especially on top of like some of these general themes.
Thank you. And I think from what you've both said, the subtlety seems to be a really important aspect and difference between passive and active suicidal ideation. Johanna, this is a little bit more on the same line, but how would you explain what passive suicidal thoughts are to someone who hasn't experienced those thoughts themselves?
Yeah, I think that this was kind of alluded to earlier about the idea that even though suicide, are you thinking about suicide or not? It's a yes or no question. Uh, there's a lot of subtlety, or we can kind of see it on a spectrum, and I think that's really helpful in understanding passive suicidal ideation. There's a lot of different components that go into it, so recognizing that. So I oftentimes kind of use an example to explore this with folks who maybe have not experienced these thoughts themselves. An example that maybe a lot of people can relate to. I don't use this in order to make light of thoughts of suicide, but I think really to help folks relate. I use an example of like going to the gym, right? Yes, do I think about going to the gym? That might be something that I think about, but whether or not I will actually do it, there's a lot of components, right? It might be, do I have the capability, right? Do I have a membership? Do I have the right shoes, right clothes, so that I can be productive at the gym, right? Do I have time in the day? So a lot of different factors that kind of play into it. And as more of those factors become more concrete, I would say that we're on the spectrum being more likely, right? Those thoughts are no longer passive, they're more active. So I use that example a lot of times to kind of help folks recognize that like just because someone is saying yes or no, or maybe they are saying no, there could be a little bit more subtlety. And that's why like kind of listening and allowing a person to talk and hearing them out can be really powerful in terms of really truly understanding um, if it's something that they are thinking about. So and I think the other thing that I would point out is that it could be a flashing thought during a moment that is really tough. It can also, passive suicidal ideation can also be something that's always at the back of the mind of someone, kind of like that chronic thought. Is how it could feel like for some people. So I think being able to recognize that it can also come in different forms. Passive suicidal ideation isn't just one size fits all, as with most things in the world, is something that I think helps folks kind of get a better picture of it as well.
Thank you so much. Kiara.
Yeah, I think that is very helpful and important. And I think the other part I was thinking about in terms of that nuance and that variety is that people have different reactions to these thoughts. And so for some people, having thoughts about being dead or about thoughts of suicide might be thoughts that are even a coping strategy that maybe feel, they feel a particular need or a particular, sort of help in a difficult time. Whereas others might be very distressed by the thoughts, and it might be very upsetting to have these thoughts, very difficult to get the thoughts out of your head, but you want them out of your head. And so knowing what that serves, we talk about that as a function of the thoughts, what purpose they serve for the person, how the person interprets them, what role the person sees of these thoughts in their life. And how distressed they are by the thoughts is really important to know because, people have different approaches, and some people may be managing this, as Johanna mentioned, something that's sort of a persistent part of their life, but they've actually feel that they're able to manage it and are used to it. And for others, it might be extremely upsetting and aversive. And another way that this can come up is also for some people, you have intrusive thoughts, which are sort of thoughts that you aren't, consciously aware of, but it just sort of come into your mind. So other ways that we see this are, having images come to mind that you can't control, it just comes to mind and it's very upsetting. And so sometimes suicidal ideation can also be that form of thought where it might not be linked to a particular behavior that the person intends, but it's just something that's coming to mind and that they find difficult to stop. And so I completely agree that really being able to have those open conversations and really understand the nuance and understand what it means to the person and how they feel about it is important, rather than sort of jumping to some sort of sort of interpretation of what it might mean that might not be correct.
That's so important. And this will kind of be a lead into the next question, but what you two are saying is so important. And I think as caregivers, something we don't realize, but it's good to talk about it. It's okay to talk about it. It's important to talk about it. And it's really having the open space for people that you're working with or caring for to be able to talk about it is so important. So thank you for reiterating that. With this next question, kind of piggybacking on that a little bit, how can we create a safe and supportive environment for someone dealing with passive suicidal thoughts? And the second part of this is, what are providers and those of us in mental health advocacy perhaps getting wrong with regards to working with people with passive suicidal thoughts? Kiara, if you want to start with this one.
Sure. So I think that to create a safe and supportive environment, it really has to be a space where a person feels that they're able to talk openly, where they're not going to be judged, where their feelings aren't going to be pushed aside. And so it really is about taking that pause and creating that space, creating spaces where someone may feel comfortable talking one-on-one, for example. So if it's with family members, really making that time for one-on-one conversation, but also really understanding that there are ways that we can signal our presence and our willingness to listen. And there are also ways that we signal our own sort of distress, our own feelings of discomfort. And those can be fairly subtle. But if a person is afraid of sharing something, and if you think about a time when you've been really nervous about sharing something with someone you love, you're really looking for those subtle signals that the person is sort of shutting down or the person is getting upset. And I think often people that are coping with very distressing thoughts are really worried about causing additional stress and strain to the people around them. them, or they're worried that something might happen. In the case of adolescents who I work with, they're worried that there might be a sort of punishment approach, that something might be taken away from them. Or people might be worried that you're going to jump to, doing something like taking them to the hospital, and it's not something that they want to do or feel that they need to do. So we really have to focus, I think, first on setting the space, on being aware of our own emotions, being aware of how we respond, and that listening to the person, I know we'll talk a little bit more about communication today, but that listening and really not jumping to that point of problem solving, of trying to fix it as though it's a problem to be solved, but that really this is an experience that a person is having. Often, something that I try to remind myself is that often even information that might be new to me as the listener, it's something that the person has been living with for some time before telling me. Sometimes, maybe it's recent, but sometimes it might even be years that a person has been sort of living with something and not talking about it. And so your experience of it in the moment is different than theirs. And we have to stay with the person's experience. Privacy is very important, and I think we do need to be honest in advance. Certainly as therapists, that's something that is important for us to do, to be honest in advance about situations where we may not be able to maintain confidentiality, and what those situations might be and how we handle that. But certainly in families, there can definitely be the impulse to involve other family members, and we really want to maintain privacy, get someone's agreement before bringing someone else in when possible. I would say to the other part about what we get wrong in the mental health field, the challenge I think we have is that, we really treat this suicidal thoughts and behaviors as a crisis. And so we need the crisis services, we need the crisis support services. We need to be aware of crisis warning signs and what to do when someone's in a crisis. But many people are living with thoughts of suicide, and it is something that they're living with, whether for a short period of time or in some cases years or even most of their life. So it's not always a crisis, right? And so the challenge of treating it as a crisis is we're always jumping to those crisis resources, when really there's also a whole continuum of just managing what, the same way that we manage health conditions, managing our mental health, thinking about how that fits into our lives and what the resources are that we need and we could benefit from, to live full lives. Along with, with these thoughts, or along with the experiences that we're having. And so I think that piece of really addressing this as a more common and daily part of a person's life is, I think, a direction that the field has gone in, moving away from only thinking about a mental health crisis and what happens at that point of crisis.
That's really important. Thank you. Johanna, and then I think we've got a question here in the chat kind of related that I'll get to after your response, Johanna.
Yeah, no, I think that that kind of covered a lot of ground on that question. A couple of things that came to mind, especially to the second part of the question, I think is the fact that there is a tiptoeing around passive suicidality. I think that I've definitely heard people say like, well, that's not really thinking about suicide though, is it? And I find that kind of, I always think about safety first. And when I think about safety first, I'm not, I want to kind of be able to plan ahead, right? And I think that that's a really big piece when it comes to just supporting someone who has thoughts of suicide, passively thoughts of death and whatnot, like being able to think about like, hey, like how does it impact you, and being able to kind of have that conversation and actually plan for safety. I know that that goes into that crisis piece a little bit, but I think that when there is no crisis is the best time to talk about the crisis and plan for that. So I think that that's a really big key. The other piece that I think a lot about, I think there was mention of confidentiality, which I think is a really big key. I think being able to also have conversations about the importance of caregivers and the importance of having a larger network. How can we kind of see if this is a safe person? Like, what are the things that we can support this person in finding that network for them? Because I think caregivers are such a big piece. So I think that could be a really big part of the work that's done by providers and those who are in mental health advocacy to sort of kind of use a little bit of motivational interviewing or whatnot to kind of figure out like, hey, like there's another perspective to this, and like we can kind of maybe find something that works for you in another way. So definitely.
That's wonderful. Thank you. I can definitely, from the caregiver side, reiterate how we do sometimes rush to want to fix in a crisis. And of course, that's because we love the people that are in our lives. And sometimes that's our initial instinct. So thanks. That's just wonderful advice that you two have given there. One comment I wanted to just, two that I wanted to point out here in the chat, someone is sharing their experience, and it says, I describe it, passive suicidality, as having autopilot thoughts. I may not actually want to die, but it's the way my brain has learned to process overwhelming experiences. So thank you for sharing that. I think that's a really useful way to have the thoughts explained to people who may not understand what it feels like. And then another question here in the chat from Ariel that I think it's very direct, but I do think it's something that as a caregiver, especially if you're not used to dealing with this, can be really overwhelming to hear. And it says, what are some things I can say to my loved one when they tell me they don't want to be alive, but they don't actively want to die? If either of you want to respond to that.
Yeah, I think that it's important to think about what the what the purpose is of the next things you're going to say, because I think there still is, often a need to get a sense of safety and to kind of confirm, that there isn't a plan. And so you still may be in a situation where you're asking follow-up questions to see where the person is, and then that in that situation you would maybe say, I heard you, and I'm also just want to be sure, that we have this full conversation, and I have a few more questions. But in the situation of, the person is telling you they don't want to be alive, they don't actively want to die, it's really, I think, about listening and exploring how that feels for them. How are they feeling in the moment? What would they like, what would they like to see happen, right? Because I think if we take the comment that came before this, it talked about, for example, for some people, it might be that feeling that this thought is really alerting me to the fact that there's a lot of stressful things going on in my life. Then the conversation really might shift to what those things are and how the caregiver might be able to support. But the person might be very distressed by the thoughts themselves and really want to do something to maybe, distract or be able to get out of that thought pattern. And so I think it's really about exploring what that first part, what those thoughts mean, and not having to, even though the thought is they don't actively want to die, there's clearly something that's happening that's distressing, and that the person may feel better talking about and making a plan for coping with.
The other thought that kind of comes to mind too is just being able to validate and normalize that feeling. And when I say normalize, I sometimes fear that that word is taken out of context. I just mean being able to recognize that, like, you're not the only person feeling this, even though it could feel like no one else has ever told you they felt that way. So it could feel like you're the only one. And validate in terms of, like, we don't necessarily have to say, like, yes, you should feel this way, right? Given everything that you've been through, but more validating that pain and the feeling that you hear, the emotions that you're hearing behind what they're saying. Um, Even if, we're not trying to say that, like, yeah, given the situation, it's valid for you to think this way. We're trying to say, like, hey, we really hear how hurt you're feeling, and also acknowledging that it's hard to talk about. I think that can be really powerful to, like, kind of just really empower and enforce that, like, hey, I really thank you for sharing with me and trusting me, and I want to be part of this process with you.
That's wonderful. Thank you both so much. Let's move on to our next question here. What are some, and again, this sort of piggybacks on what we just talked about, what are some resources or strategies to aid caregivers in supporting a loved one? And Johanna, we'll let you start here.
Yeah. When I think about strategies, I think there's a couple of pieces here. In my work with caregivers, I've found that a lot of caregivers find themselves thrown into a situation where they're supporting someone who's thinking about suicide, rather than having the opportunity to kind of prepare. So I'll always say, if you're like, when is a good time for me to get some knowledge around this to prepare myself, now is probably just as good as any, right? Because I think you just kind of never know, kind of like the idea of learning first aid skills, very similar in that way. When it comes to, we talked about kind of listening, talking directly about the topic, not beating around the bush. I think those are really important things. I always say that, like, especially as you are growing in the caregiver role, taking time to recognize how maybe your relationship with this person has shifted. We hear a lot from caregivers that they experience different forms of grief, in the sense that, like, this person is here, but some of the experiences that I envisioned having with this person look a little bit different now, or our relationship doesn't look the same as I thought it would. Being able to process through that, and also process through your own experiences with suicide, I think that could really kind of inform the approach that you take, and could be really important in terms of helping you connect and have meaningful interactions with the person that you're supporting. So thinking about, I've worked with folks who talk about, I've had thoughts of suicide myself. So I really just want to tell them that it's okay, hold them, and do all of that. And sometimes that, that lived experience is so incredibly important, and can really help you understand the person. Other times it could also lead someone to maybe activate some of their own thoughts, or maybe there could be an over, like, cast of, like, hey, like, I understand what this is, and they must be going through the exact same thing that I was, right? So I think being very aware of, like, what you bring into the conversation, your own experiences with suicide, and how that might impact you as a caregiver, can really help inform your approach. Maybe you've not had a lot of familiarity with suicide, and in your background it's kind of not talked about, or maybe it's even seen as something that's a sin in the culture and families that you grew up in. Thinking through that, how do I don't have to change my belief, but how can I make sure that when I'm having a conversation about suicide, that belief doesn't hurt the relationship that I'm trying to build with the person that I'm caring for. So I think that is a really important strategy to kind of think about. Learning kind of the questions to ask, asking about a plan, being able to really kind of differentiate between passive suicidal ideation and active thoughts, making sure that, hey, this is a situation that this person needs someone to listen to, rather than, like, hey, maybe we need to get someone else involved. I think being able to kind of learn those triaging skills can be really helpful. And then regularly checking in with the person, helping, and recognizing that sometimes supporting someone who's thinking about suicide passively might look like helping with routine tasks. It might look like, hey, like, let's do your laundry together so you don't have to do it by yourself. Or, like, let me, like, go grocery shopping for you this week. It might look like something small like that. And that could be a huge support. So kind of being creative in the way that you think about how you provide care. And then one thing that I think is just really important is taking care of yourself as a caregiver. I think that a lot of caregivers that we hear from often say that, like, I didn't realize until a couple months in that I'm maybe biting off a little bit more than I can chew. And they kind of start to realize that, like, hey, this might, for this to be sustainable, I need to start kind of making sure that I'm aware of my own needs. So I think that could be a really big part of it. Lisa, you had mentioned earlier that I co-founded Suicide is Different. We offer a lot of resources that kind of outline some of these strategies. So I think that we're a good resource. And I think the other resource I really want to highlight is calling 988. I think a lot of caregivers don't realize that you can call a crisis line as someone who's concerned for another individual, and that crisis counselors are actually trained to have conversations around how to support another person who's thinking about suicide. So recognizing that that's always going to be an option 24/7 for you.
Oh, that's so good to know. I have to admit, as a caregiver myself, I did not know that. So that's wonderful. Thank you. Kiana, do you have anything to add? And then I have 2 points in the chat I'll bring into the conversation too.
Yeah, no, I think that was very comprehensive and helpful. And I think, I was definitely thinking about the fact, I think often about how we often throw caregivers, especially in my area of work when thinking about adolescents, young adults, we sort of throw caregivers into a professional role, essentially, of saying, now you're responsible for this person's safety, you're responsible for getting them therapy, for getting them to therapy. And we sort of expect all of these things without really taking into account what the caregiver's experience is and what they're going through. And I think, as Johanna mentioned, especially I think in the area of suicide, because there's been so much stigma, so many silences, I find that often when someone, is exposed to the experience of somebody else having suicidal thoughts, or the information comes up, it really brings up for many people things that have been sort of, pushed back in their past. And so it's not uncommon to then sit down with a parent and hear about their own experience of having had, even a suicide attempt that was maybe, when they were a teenager and then never talked about again, or a person in their neighborhood, or something that they remember that was very upsetting. But because they didn't have a chance to talk about that or process it because of these societal silences, I think it can really create, I think, as Johanna was alluding to, many layers of experience. And so there's your experience as the caregiver, but there's also everything that you're going through and processing. And just the fact that it is just such an incredibly stressful experience, right? Because it's all of the challenges, of caregiving, but also with this real fear, for the person that you're caring for, the fear of what might happen, of what they might do. And I know that, one thing that impacted me years ago in talking to a parent of a child with suicidal ideation is she said, if my child had attempted suicide, I would feel that there were actually more resources and more people to talk to in a way, because there would have been sort of a behavior that we could talk about. But because what we're talking about is her thoughts, it's not taken as seriously. And so I would hope that that's changing in terms of the resources that we have available, and, really wonderful organizations like this one, and like Suicide is Different. But I do think that feeling, that thoughts are not taken as seriously as behaviors, even though thoughts, are really indicating underlying deep distress and are really impacting people's lives, and are also creating a lot of fear and uncertainty. So having that self-compassion, knowing that is happening, and also knowing that, ultimately, we can't control the actions of other people. And that's important because even though that creates fear, right? It's scary to think, well, I can't make this person do the thing I would want them to do, or I can't, fully control their behaviors to protect them. But on the other hand, what I also try to remember is that also is about respect for people, right? Respect for people's autonomy, respect for their own process, and journey through life. And so when we can kind of be in relationship with that feeling of respect, then we also open up the space, for people to feel supported and to feel that they're able to do the things that they need to do to support themselves. And that's ultimately where we're hoping, is that, through that connection to caregivers, it's really about supporting the individual and empowering the individual as well.
Oh, that's wonderful. Everyone deserves the dignity of their own experience is something that was really helpful to me throughout the years I was caregiving. One of the questions in the chat here is, what talking points can you offer family members who hear, you don't understand how I feel? And I think this gets to sometimes the pushback that can happen when caregiving is initiated and there's resistance, or perhaps the person having the thoughts isn't feeling heard or understood. Do you have any advice you can give in that scenario to ways to open up the realm of understanding and conversation?
My first thought when I see that is just acknowledging that the person's right. I think kind of, and being able to kind of connect with them on that human level of, like, you're right. Like, I don't, and I'm not trying to claim that I do. I really like to get a better understanding, and I think opening up that conversation could be really powerful. And I think sometimes just acknowledgement is something that folks are looking for, not necessarily that you can reiterate their whole experience. So I feel like that could be really powerful.
Yeah, I think that makes a lot of sense. And I think that feeling that, we want these to be conversations, right? We don't want a person to feel that they're being sort of interviewed. And so I think sometimes that can happen. Has been our goal to understand and to really understand. We keep asking follow-up questions, right? And then we hear that sort of pushback, like you're asking me these questions. And when really, I think that the point is well made, that the person may just want to hear that acknowledgement that this is really difficult, or they do feel so alone and they do feel that nobody understands or has not been through what they've been through. And it's just so important to acknowledge that, and also to find other ways to connect to other things that might help, or just being in present with that person and being in companionship with that person, even if there isn't maybe in that moment a conversation to be had, or the person doesn't want to have a conversation further. And I think also continuing to be honest and authentic in terms of expressing what your goals are and having that conversation, because sometimes you might find yourself down that line of, oh, I asked too many questions and now the person's frustrated with me, and saying, I'm sorry, it sounds like that was frustrating. And the reason I asked so many questions is because I do really want to understand, or because it's so important to me to understand your perspective or to hear where you're coming from. But also I get that that wasn't the right way to go about it for you. And we can kind of switch, gears. So always important too, to know that these conversations and these, none of us are perfect. We're not going to get it right every time. This is a human interaction, but being open and honest, authentic, being willing to repair when there is a problem really goes a very long way.
That's great. Thank you. And that kind of leads back into the next question, Kiara, which you're going to take, which is what are some effective communication strategies when discussing passive suicidal thoughts with a loved one? And somebody here asked a question that might give a little bit more nuance to that, which is how would you guide caregivers who are afraid that what they might say or do would push a loved one beyond passive suicidal ideation? Sometimes it freezes caregivers from taking a step to approaching loved ones. So incorporating how are the effective communication strategies, and in this particular scenario, what you might do.
Yeah, no, thank you. That's very helpful. And thank you for that question, because I think, and that reflection that this is part of what freezes caregivers. And I would say it's the same for clinicians, for healthcare providers. I mean, for folks that are in this space, there still can be a lot of fear around having these conversations openly. The most important thing that we always want to reiterate is that it is important to use the correct terms. We have research showing that asking about suicide does not increase the risk of suicide. We even have research now showing that asking about it repeatedly, because we have studies now that are doing these sort of daily assessments and really asking people regularly, does not increase risk. And so what we want is to use the correct terms, just like, we want to say cancer when we mean cancer. We want to say suicide when we mean suicide. We don't want to talk around it or have this sort of taboo around a word or a topic, because that really creates the impression that there is shame, that there's a reason not to talk about this directly, that the thing that you're thinking about is something that, can't be spoken about in all situations. And so that's why you hear us talking openly, asking questions directly, like, have you had thoughts about killing yourself? I mean, that sounds harsh and it sounds stark to people, but it's the reality, and it can open up that conversation to talk about something directly and be very clear what you mean. And so that's the starting point, is that, not to be afraid to use that correct terminology, not to be afraid to talk about it, to talk about the ideation, because what I would say is, we do recommend, and this is true also for mass media and social media posts, we recommend not talking about methods. We recommend not talking about specific ways that somebody might be attempting, or things that they might be doing to hurt themselves, because talking more in detail about methods can potentially cause someone to think about that method, or just kind of trigger some of those thoughts. So we do try to avoid that in the sense of introducing that. So if you're talking to somebody, you might not be introducing that topic. But talking to them about the fact that they're experiencing ideation is not something that's going to be harmful to them. It's not going to be something that moves them to thinking about, to a different type of ideation. And it may actually really help, because now they have a place where they can speak openly and where they can kind of get that support around what they're feeling. And if they introduce a topic to you, if they're telling you about a method that they're considering, then it's okay to ask some follow-up questions to confirm, what you might be able to do to help keep them safe, because sometimes people are looking also they have something that they're fearful they might do, and there might be ways that a caregiver can support them in, limiting access to that method and taking something out of the house, or in just even hearing them out when they say, it was really hard to avoid doing this today, for example. So that would be the starting point, is really talking directly, really getting used to that, because again, it's hard. If we're not used to it, it's hard to get used to you talking about things directly. So if you have somebody else in your life that you can practice with, or just watching, you know, things like this, watching, you know, the kinds of videos, being in those kinds of peer discussions that places like Families for Depression Awareness have, or the American Foundation for Suicide Prevention, that can also help you get comfortable with the terminology. You know, even as a therapist, you often are reading scripts of things before you actually do them, because it helps you kind of hear, how did somebody else formulate this? How did somebody else talk about this? And then we've talked a lot about kind of listening, you know, without judgment, not having that emotional reaction in the moment. That doesn't mean you don't show emotion, but it means you don't sort of put your emotions on the person of, you know, how distressing this is or how upset you are. You don't center your own emotions, you know, in the moment. If you have, you know, emotional reactions, you can explain, you know, why you're feeling that way, but you really want to stay in the moment and give space for the person to talk, you know, reflect back what they're saying. And as you know, as you mentioned, I think very well, Lisa, the instinct to problem solve is an important one, because we do this because we care about people and because we want to solve the problem. You know, we want to help, we want to give advice, but it does shut down communication if that's not what the person is looking for. I mean, you can always ask, you know, are you looking for help around problem solving? Do you want to brainstorm solutions? But most importantly, it's really about listening and about just noticing, oh, that's me trying to problem solve again. Let me stop and like listen to what the person's saying. Let me pause. Let me ask them what they need. And, you know, ideally, if you have people in your life that you can sort of debrief with or talk about your own feelings about this afterwards, doing that as well, because these are difficult conversations, you know, to have.
Thank you, Kiara. So helpful. Johanna, do you have anything you'd like to add to that?
Yeah, I think the one thing that I would also I think of this as a communication strategy is to recognize that this is a heavy topic, right? It could be something that isn't common and therefore feel unnatural in the beginning. And I think Kiara, you just mentioned that, like, to find a place to debrief for yourself, but also thinking about the pre-work that's done, right? And what I mean by pre-work is not kind of expecting that, like, when I'm ready to talk about it, the other person is also ready to talk about it. I always suggest to caregivers, like, ask if it's a good time, and if it's not, like, schedule some time that might be a better time. And of course, if there are safety concerns, those need to be addressed maybe more promptly, but recognizing that, like, kind of preparedness going into a conversation and not catching someone, like, I remember, like, whenever I'm kind of caught off guard by someone wanting to have a very serious conversation, it could feel like I'm being put on the spot. So being very aware of that, I think, is a really big piece of this too.
That's wonderful. That is great. Thank you. I'm going to go into the next question, and there's two things in the chat. I'm going to work into this so we can answer those questions within this one. What role does professional mental health support play in this context, and how can caregivers facilitate access to it? And when is the right time to seek professional help? And someone in the chat had asked for a little bit more definition about what's differentiating active suicidal thoughts and when, I guess, you know, as a caregiver to know. And then someone was wondering about if loved ones' thoughts and words are spiraling excessively. So maybe you feel like you're not able to communicate, or the crisis feels like it's building. So yeah, at what point do we involve mental health? How do we do that? And when do we know?
Yeah, it's a great question. I think that there's, I personally don't think that there's a wrong time to seek professional help. I think that the caregiver's comfortability plays a big role, right? Like, if there at any point you're starting to feel like, you know what, I don't know what to say, I feel very unprepared for this. Um, I think it's about knowing, like, what type of help, right? So maybe in that situation, calling up the 988 number together, and or potentially, like, calling before you have the conversation to prepare for what you can say in the conversation, or directing the person that you're supporting to call on their own, but kind of thinking about, like, what levels of professional support, because if someone is actively thinking about suicide, um, that might be a time, if they have a plan, they've been thinking about when they would be doing this, we might want to escalate it to taking them to the emergency room if needed, or maybe, like, we need to call mobile crisis team. So I think there's no wrong time to reach out to professional help. It might be more so, like, what type of help to kind of reach out at what point. I think that's a big piece of it. In terms of how professional mental health supports could play a role, I think, right, ranges from kind of, again, on a spectrum, right, from crisis line supports to outpatient therapy to like potentially some programs that people can go to more on a daily basis, or maybe even a couple times a week to a hospital program. There's a lot of different varieties, but I think that caregivers can play a huge role in facilitating access in terms of knowing, hey, like when which level might be appropriate, and then also recognizing that, hey, I don't know. If you don't know, that's okay. That's what kind of like the 988 and 24/7 supports are there to kind of help guide you through. And then also, I think recognizing that if someone is not willing to go seek professional support, I think caregivers can play a huge role in, hey, like I'm kind of curious as to why that is, right? And I think because knowing where the resistance comes from can be really helpful. If someone has a lot of fear because they're scared that they're going to be taken to that like highest level of care, like being hospitalized, maybe, hey, like, is there a way that we could talk to some mental health professionals to kind of ask questions, like can we call 988 together and ask some of these questions, and get some clarity around what mental health care actually means, what therapy actually looks like. Can I schedule some consultations with some therapists to get a sense of how they would approach supporting someone like this? So I think a big part that caregivers can do to facilitate the process is be able to kind of be that peer, that friend, or maybe in some situations like, the parent, whatnot, to weigh the different options and provide some education in terms of getting information about what getting connected to care looks like. And I think that that's a huge kind of bridge that caregivers can play.
That's wonderful. Thank you. Thank you. Kiara, do you have anything you'd like to add to that?
Yeah, I think I just completely agree in the sense of, mental health support can be so helpful in times that are not in crisis, when you're really, able to make those plans and work through the things that may be happening that moment. And also that since we know, the mental health system can be very difficult to navigate, I think often similar to what Johanna said earlier in the chat, the time to plan is when things are actually fairly calm. And so if you are at a point where there's not an immediate need, but it's a good time to get on wait list to figure out what the resources are in your area. And sometimes the person, may be willing to at least see a therapist once to test out if there's a fit. And so looking into those resources and options. And I think in this question of, distinguishing between passive and active, distinguishing with it from the perspective of a caregiver in many ways is just about understanding the person's experience, understanding what they're feeling. In the sense of assessing risk, I mean, you do want to elevate, to thinking that there's sort of an immediate crisis. If someone really has a plan, they're talking about doing something about dying by suicide, imminently, that day, the next day, there's something active that they're going to do, or they've really thought out how they're going to do. That's one of the things that we think about. But we also know that even though we've talked about this a little bit as a continuum, it's not, a linear process. It's not that someone goes from passive to active to then an attempt, and you can sort of follow the path that someone goes down. Unfortunately, right? There's a lot that we don't know. And so people who have passive SI are still at risk for attempts. There are some people that have attempts and don't really trace a history of ideation before that either. There can be just different types and different things that happen. So it is important to, really notice what's going on with the person in the moment when you're thinking about that moment of crisis, but not feeling that, there's this sort of transition from passive to active that you might need to be kind of watching for, because it's really more about understanding, kind of their plans, changes in behavior, changes, from the usual. And what else would I say? I think the other pieces are thinking about, what are the resources that maybe if somebody doesn't want to engage in mental health care, there's one book by Dr. Catherine Gordon, which is called the Suicidal Thoughts Workbook, which is really cognitive behavioral therapy skills, an evidence-based approach, but to really managing suicidal thoughts. And so that's one resource. That there are some things, out there that you're really looking for them to be coming from an evidence-based, strategy, something that has really worked, for a number of people, or been tested in some way, but that can be helpful for sort of self-care and self, at-home practices for people that are more comfortable with that, or seeking out peer support. Systems can also be another helpful approach.
That's wonderful. Thank you. We have in the chat here, Ariel offers using psychiatric advanced directives can be a great way to plan before a crisis. I don't know if either of you want to speak to what that might look like, in case someone in the audience doesn't know.
Yeah, so I think that, in typically, so I think what they're speaking about is really kind of in the same way that you'd have advanced directives for what you want to have happen, if you're incapacitated, for a medical condition or due to an accident, that you can have, really written out and worked through what you would want to have happen when you're in a mental health crisis. Because most of my work is with children and adolescents, I haven't typically used it in that context, that it's a psychiatric advanced directive. I think what we're often thinking about is a safety plan, which is another tool, that can be used to plan out, to think about what it is that the person might need. So in the moment of crisis, they're not able to tell you these are the things that will help me right now, but that you have a sense of what might help, what might be useful, what they would like to have happen. But it sounds like what Ariel is speaking to is even, another layer, of more formally having an advanced directive, so that not just caregivers but potentially folks in a hospital, for example, would have some guidelines to adhere to, and to know the level of care that a person is comfortable with, and if there are certain things that they don't want to have happen, that would be known in advance. I think the other reason that that's helpful is because that could also cut down, hopefully, on family conflict. If there's family members that disagree on what a person might want, you have that documented from their perspective. But certainly great to hear, any resources, in that regard, or if anyone has used that.
One thing I would add from the caregiver perspective before our last question is, it's okay if you feel it's appropriate if someone is for the first time engaging with a mental health professional, and it's appropriate, and again, case by case basis, to ask if you can accompany, at least just for a bit of that appointment, in case the person that you're working with is lacking insight or has stigma and doesn't feel like they're comfortable talking about it with a mental health professional, that sometimes as a caregiver, offering up that opportunity to go with them, to be with them for part of that appointment, is appropriate if that's what the person wants. And I found at times that can be very, very helpful when you're working with an adult. Obviously, with adolescents, there's different things at play there. So for our last question here, how can caregivers balance their own mental health needs while supporting a loved one? And Kiara, we'll turn to you to start with this one.
Wonderful. I also realized I wasn't sure if we spoke entirely to the question around if you feel that someone's not able to communicate anymore, that they're really kind of, it sounded like there was a question around jumbled in their thoughts and their communication.
Yes. Yep. Yeah. About increasingly spiraling in excessive thoughts.
Yeah, spiraling excessively. Yeah, so I think, if I'm interpreting that correctly, I think if we're talking about a kind of spiraling, that really can be a sign, of a crisis, of something that, is starting to get sort of out of control for the person. And depending on, there can be a number of different reasons why that might be happening. I mean, it could be due in the moment to stress, but there are also, reasons why someone's communication might be impaired, whether due to mental health, or physical conditions. And so I think that really is an instance where you want to get some sort of mental health evaluation. You really want to get a professional involved to be able to assess what's going on, and what might be helpful, or call 988 to walk you through it, to some strategies if you're not able to do that. Now, if the question is they're spiraling excessively sort of in the moment, what's happening is really upsetting them, I think you have to really go with the standpoint that regulation and the opportunity for emotional regulation always has to come first before having a conversation. There's no reason to push a conversation when someone is feeling, dysregulated, escalating in terms of their thoughts, and feelings. You really want it to be whatever they need to be able to calm down, to feel comfortable, to feel safe in that environment is really what needs to come first, and sort of conversation and sort of other kind of, strategies can come later. So that might be taking time, for a walk, taking time, to calm themselves. And so I think this speaks to then the kind of supporting your own mental health needs. I think we all hear a lot about self-care, and it's challenging. There's a lot of reasons why, we might not have the time, the money, the mental space, feeling like we're really being pushed in a lot of directions. And also I think the guilt, right? The feeling that this is an all-consuming role, that we really need to be there for other people. And it's not right for us to pause and take care of ourselves because we may feel that comparatively, we're doing okay, we can push through. So being aware of those thoughts that you might have that get in the way of you caring for yourself, and recognizing that your own well-being definitely benefits, you and those around you. And thinking about those small steps. And so I think, the simple things like setting, a kind of calm alarm on your phone, a nice little like song that plays once a day so that you can really take that pause even for a minute or two, and maybe start extending that, taking time in that moment, these little micro breaks to notice how you're feeling, thinking about one thing that might take you in the direction of feeling better or more balanced that day. But I think small changes, rather than pressuring ourselves for the really big changes, as well as really being aware of our daily routines, social connections, engaging with things that bring us joy, like art, writing, or that bring up other perspectives. Those can all be forms, of connecting with what helps us feel more balanced.
Thank you. We're almost out of time, but Johanna, if you have a quick thought here to put at the end.
Yeah, I think a lot of times when we think about self-care, it is a lot of what can we add, but I think sometimes it's what can we take out, like what can we not do so much of, or what types of knowing our limits. So I think that's another big piece. But yeah, no, I think everything that was said is definitely important, and glad we're able to cover it.
Well, thank you both so much. We're so appreciative of your stories, professional expertise, and all of your thoughts about passive suicidal ideation. Thank you to everyone who's watched live or is going to watch this recording. We hope that this information empowers you, your loved ones, and your family. If you'd like to keep learning with us, please go to our website, familyaware.org, and sign up for our newsletter. And we would appreciate it if you would fill out the survey when you get a chance. Thank you so much.